Introduction. I hope I live up to my standards. Right? So, first speaker on a very terrific topic. First question, that's good. It's okay. Is Dr. Amina Mobashir, who will be talking about Benralizumab. That's a tongue twister. I'll tell you the code behind how you do it. Now, she's a senior consultant pulmonologist at Max Super Specialty Hospital. Okay. She's a senior consultant pulmonologist at Max Super Specialty Hospital, Saket. Her expertise is in critical care, allergy and immunology, and interventional pulmonology.
अभी रुक जाओ भाई.
Good evening, everyone. Thank you for having me here once again. It is an absolute privilege and a matter of pride for me to be able to present anything in front of such an esteemed gathering. So today, my topic is on the face of it is a little dry and drab because we're going to be talking a lot of numbers, a lot of data. But why it is important is because it reinforces our belief in the role of biologics in the real world. We have a lot of data, the pre-marketing data, which we've been talking about earlier, but here we're going to discuss about what is happening in the real world. And we have a lot of studies to back that. So, to begin with, what is the importance of RCTs? Of course, we know that RCTs are the most standard and most significant data in terms of whenever we are talking of any drug or any therapy or any treatment recommendation. Now, as far as the Benralizumab is concerned, it is a biological agent which was introduced a few years ago. And it is also indicated in the GINA guidelines for the management of severe asthma as a step 5 therapy. And we have ourselves used it in a lot of patients with excellent responses in each one of them, and I would say not even a single adverse effect so far, luckily. Now, these studies mentioned here are a few of the studies in which Benralizumab has been studied. Now, in terms of the real world evidence, again the importance, like I was just saying, is that you obtain a comparative effectiveness data. It provides support for regulatory approval, adherence, and it explores the drug safety data in a broader population. So the programs in which Benralizumab has real world data are Zephyr, Zalog, BPAP, and Nangia, to name a few. So talking briefly about the Zephyr-1 study, the objective of this study was to characterize the population of patients with asthma treated with Benralizumab in terms of patient demographics, comorbidities, and other asthma medications, and to understand the benefit of Benralizumab on asthma exacerbations. So this study very beautifully enrolled patients 12 months prior to the index date, and then Benralizumab was started, and the patients have been studied for up to 12 months post starting of the Benralizumab therapy. The primary cohort here was patients with at least 2 asthma exacerbation episodes during the 12 months pre-index, as in before starting the Benralizumab therapy. The key secondary cohort was the persistent group, which included patients with at least 6 records of Benralizumab. So this becomes important here because we know that Benralizumab or any other biologic for that matter would not instantly start showing its effect. You have to give a patient at least 4 to 6 dosages before we see a significant response. The other cohorts in this study were patients who had switched from omalizumab to benralizumab and patients who had switched from mepolizumab to benralizumab. So if I sort of summarize this, what we see here is that there was a significant reduction in exacerbation in the primary cohort and the persistent group. So the tunes of a difference of 55% and with a significant p-value also in this case. So statistically significant improvement in the number of exacerbations is what we see here. The other group in which the patients had switched from omalizumab and mepolizumab to Benralizumab also showed a significant difference in terms of reduction in the exacerbations with a significant p-value again. Then moving on to the next, Zephyr 2 effectiveness study, pretty much the same. It characterized patients who were treated with Benralizumab with up to 24 months of follow-up data. So this is a longer study, more robust data. In this also we see that in any setting, a surgery or a non-surgery cohort in patients with comorbid nasal polyposis, we did see a significant drop in the asthma exacerbations, and we have known this very well, and we've been emphasizing this fact in our prior lectures also, that patients who have severe asthma and also have nasal polyposis along with T2 inflammation, which means eosinophilia and a high IgE. So there's this particular subset of patients who also have nasal polyposis who respond beautifully and wonderfully to Benralizumab, even in terms of their symptoms of the sinusitis and polyposis. So as we see in this slide also, if you look at the blood eosinophil level, the reductions in exacerbations across all blood eosinophil levels were significant. Then reductions in asthma exacerbations over a 2-year period are also statistically significant. Again, in this study also we examined patients who had switched from other biological therapies. So we see a 62% and 53% decline respectively in patients who transitioned from omalizumab and mepolizumab. Then another Zalog studies across the globe, multiple countries, we've studied the effect of Benralizumab, again showing that the exacerbation rate much lesser in patients who have received Benralizumab. Then a fourth study here is the BPAP study, which also shows that Benralizumab reduces asthma exacerbations by 85% in OCS dose versus baseline in real world clinical settings. So we have again, mentioned this multiple times, and we've discussed this, that a lot of patients who come to us with severe asthma are on some baseline dose of maintenance oral corticosteroids, which they're not able to get rid of. I'm not talking here about the inhaled corticosteroids. We are discussing the oral corticosteroids. So a lot of patients remain stuck with that 10 mg Visolone or a Medrol 4 mg, and they're not able to sort of get off this oral corticosteroid. And we've seen wonderful responses in the sense that a lot of our patients have indeed got off this oral steroid therapy and have only been continuing their regular inhalers and are doing very well. So this study here is also, sort of emphasizing the same fact. Another ANAN case study, a real-world AER reduction, again observed in both atopic and non-atopic patients. So a common question here is that, a lot of people ask us that in patients who are non-atopic, meaning who don't have any overt symptoms of allergy like a rash or something, would they also be candidates for Benralizumab? The answer is yes, because you don't necessarily need to have an atopy to receive a biological agent for the treatment of severe asthma. You just need to have severe asthma despite appropriate therapy, and you have to have a type 2 inflammation with or without atopy. So this study mentions just the same, that it works effectively, as effectively even for patients who do not have atopic features. So most studies improve asthma, again, sort of showing the same results. I'm not going to bore you all with more data, but this here is important because this is a real world experience with Benralizumab in Indian patients. published by a dear friend of mine and her colleagues, Dr. Mishram from Bombay. So they have published a series of 6 cases here, in which the blood eosinophil levels in most of them were high, to the tunes of 1400 even, and the IgE levels were high in 4 of these 6 cases. The first case had recurrent exacerbations, second one had more than 2 in a year, third one also pretty much the same, and the 6th case had 5 exacerbations in the last year. They've mentioned the other comorbidities. One of them had obstructive sleep apnea. OCS use in all of them pretty much. Like I was just mentioning that this is a big problem and a challenge that we face in our day-to-day practice. Patients with asthma coming with like a regular oral steroid intake, some of them even taking steroids on their own, that I felt breathless and I took a 16 mg of Medrol and now things are better. So after Benralizumab treatment in each of these 6 patients, there was elimination of OCS use in the first patient, no oral corticosteroids were administered in the second patient, no OCS bursts, again 4th case also no oral corticosteroids. So basically this case series also emphasizes the fact that with the appropriate and timely addition of a biological agent, and in this case we are talking of Benralizumab, very specific, with very specific indications, timely administration of these biological agents would save our patients, one, a lot of distress related to the daily usage of oral corticosteroids, asthma exacerbations per se, and most of them are able to maintain a stable state with just the regular inhaler use. So to summarize, Benralizumab has proven efficacy in real-world experience. It's achieving exacerbation reduction for biological naive and even for patients who have switched from other therapies. And in fact, we ourselves have 2 patients, one of ABPA and other of severe asthma, who we switched over from Omalizumab to Benralizumab, and both of them are now doing very well. In fact, one of them is off Benralizumab, and I just met her daughter last week. She happens to be in our HR. So I asked her how her mother is doing, and she said she's quite good and she doesn't want to see the face of the hospital now. So that was good and bad. Anyway, coming back to this, so Benralizumab has a proven efficacy for patients with eosinophilic asthma and comorbid rhinosinusitis with nasal polyposis. Very important. If you see this subset of patients with eosinophilia and polyps and severe asthma which is not getting controlled, they respond beautifully, and we've seen this. And like I was mentioning, that irrespective of the atopy status, the patients do respond well if they fit into the, of course, if they have to fit into the clinical criteria for Benrali. That's something that Astra wants to say to you. This is the prescribing information. If I have to just quickly summarize it. So Cassandra, we have a very easy to administer self-injecting pen like insulin. It's 30 mg and it takes about a few minutes for the patient to receive this medicine. The first 3 dosages are at intervals of 1 month, and then it's given at an interval of 2 months. When to stop it has been a question that is asked very frequently, so we do not so far have data on, or guidelines, I would say, as to when to stop it. It's like you continue at least for 12 to 14 months. You try and stop it and see if the patient is doing well. Otherwise, it just becomes a part of life, and people, do very well with it. So it's the first dose can be in the hospital. The subsequent dosages can be taken at home, and it is covered by most insurances also. So that is also not an issue. Yes. So the cost for the first 5 months, which is 4 dosages, is close to 2 lakh rupees. It is also available in CGHS and ECHS, yes, very important. So I guess we take the rest of the questions after Dr. Nangia's talk. Thank you so much for your patient listening.
Okay, so after a wonderful talk by Dr. Amina, we got Dr. Vivek Nangia. Nangia, I can say that he's the Vice Chairman and Head Pulmonology at Max Super Specialty Hospital, Saket. He's an internationally renowned intervention pulmonologist with over 20 years of glorious clinical experience. He's pioneered a lot of bronchoscopic intervention procedures and medical thoracoscopy in Delhi. He's extensively trained in critical care medicine from USA and UK. Over to you.
Thank you, Dr. Kapoor sir, for those kind words of introduction, and thank you all of you for joining in this evening. It's really a pleasure and privilege for us as a team from Max Hospital representing the Pulmonary Critical Care and Sleep Medicine Department to be here amongst all of you this evening. And we always consider it an honor and a great interactive session, enjoyable interactive session. Dr. Tulsi is smiling at me the way he's looking at me. I know we're coming to the end and the questions are yet to begin. As Dr. Chauhan would always say that the Viva begins only after the question paper has ended, so we shall wait for that anyway. And but more than that, I would like to thank Dr. Amina for joining us this evening. She wasn't, despite her illness, I mean, it's very commendable that she's just recovering from a Guillain-Barré syndrome, and still she has come all the way to present. And also it's a proud moment for us because we have somebody new who's joined our team, and that is our son, Dr. Siddhant Nangia. He just completed his MD Pulmonology and has come back to Delhi and has joined us. So you'll be seeing more of him now in this forum as well. So now coming on to the topic for this evening, COPD. I'm sure all of you see these patients day in and day out. COPD is a very common illness. Of course, earlier you would link it with exposure to cigarette smoke, but now we see it in non-smokers also. There are enough studies which have shown that 50% of the COPD burden is amongst the non-smokers. That doesn't mean that the smokers are able to justify it and continue smoking, but that only means that even the non-smokers need to be careful of developing this disease. There are about 38 million people who are suffering, and it's underdiagnosed. Why is it underdiagnosed? Because we don't bother to get a PFT done for our patients. Patients come to us, we check the wheezing, we advise them the standard medication, the nebulizers and the inhalers and the refilling tablets. They go back home, they feel better in 2-3 weeks time, and then they discontinue the treatment. And then again they would come back after 3 months, 4 months, and gradually what happens is when you have a constant wheeze in the chest, the body starts getting used to that wheeze. You know, when you have a restriction in your breathing, in your abilities. So supposing there was a patient who was earlier walking, say 500 meters, I mean of course people walk longer than that, but I'm just saying 500 meters covering in 5 minutes, now they are covering the same distance but in 10 minutes. And then, so once first the speed slows down, then the distance cover slows down, which you don't realize over a period of time. But what is happening is that the airways are going into a permanent bronchoconstriction inside and not to recover ever again because they become fibrotic from inside. Therefore, it is important to catch them early and treat them early. It has become one of the most common causes of mortality amongst the non-communicable diseases. COPD is the second largest killer in our country after the ischemic heart disease, and of course diarrheal illnesses come below them. Over half of the patients with COPD remain undiagnosed, and COPD alone does not result in death. COPD is also linked with the cardiovascular system because ultimately both of them are in the chest, and oxygenation, blood transfer, everything is interrelated. So as a result, the mortality is higher also because there is a cardiovascular component attached to it. Exacerbations increase the risk of death. One exacerbation in itself is a predisposing factor for the next exacerbation. If somebody, only about 50% of the patients were alive within 3.5 years of their first severe exacerbation, that resulted in hospitalization, required high dose of steroids, antibiotics. Imagine 50% of patients of COPD who are landing up into the ICU of a hospital within 3.5 years are likely to die. That is the kind of burden, mortality that COPD can cause, which gets ignored completely. With 2 moderate exacerbation, the risk of death is increased by almost 1.8%, 80%, sorry. Even 1 moderate exacerbation increases the risk of cardiopulmonary death by 17%, and if it is cardiovascular, then about 23%. So the exacerbations need to be prevented, and I'll just come to that. If you see this chart here, this graph, it shows that the gap between first and the second exacerbation was about 5.4 years. But then after that, this gap went on narrowing in this study. So what does it mean? That one exacerbation in itself is a predisposing factor or a risk factor for the next exacerbation. That is why it is so important to be able to control the disease very well during these periods. We are lucky to have Dr. Chauhan also joining us here. Dr. Chauhan, welcome please, and congratulations on Mrs. Chauhan being felicitated by DM. Otherwise, if you see a patient of COPD, sorry for this slide, probably it's not visible clearly, undergoes this vicious spiral of COPD. So there is exacerbation that results in cardiovascular events. Atrial fibrillation is very, very common. In fact, it becomes difficult for us to explain to the families. Patient तो ठीक ठाक आया था, पर यहाँ आते उसको atrial fibrillation कैसे हो गया? So COPD is known to result in these kind of cardiac issues: atrial fibrillation, coronary artery disease, heart failures, cor pulmonale. So there are various ways that you can connect COPD with heart. And of course, gradually over a period of time, there is wasting of all these muscles, deconditioning, resulting in limited physical activities, poor quality of life, gradually depression and psychosocial problems start setting in because these people are not able to perform as they would want to. They feel they are still young and they are still healthy, but ultimately they don't realize that they are just losing muscle mass, losing weight. Sometimes people with COPD come, they've been losing weight because they've been undergoing one exacerbation after the other. So ultimately, death is the answer in all these patients. And it isn't only those people who have a high symptomatology, even those with the low symptomatology, low symptom burden are susceptible to exacerbation. A simple viral infection, simple exposure to dust, fumes, chemicals, anything could result in an exacerbation. Therefore, it is important to identify the risk factors and identify to treat these exacerbations early and be able to prevent these exacerbations is what is more important than anything else. So history of COPD exacerbation is a strong predictor of future exacerbation, as I said. Increased dyspnea, productive cough are associated with higher exacerbation risk. And one factor that you can keep checking in your patients is the eosinophil levels. As Dr. Amina just discussed with you about Benralizumab, eosinophil, asthma. Eosinophils in COPD are also now being known to play a significant role in the pathophysiology. I mean, not as much as pathophysiology, but in the inflammatory cascade. All our life, we've always known that COPD is a neutrophilic inflammatory disease. But now we realize that eosinophils are also playing a part in that bit of inflammation that they have. So there are 3 components that are there in a patient with COPD. The inflammation component, the hyperinflation, where the lungs are just getting hyperinflated because they're not able to deflate, the air is not able to go out, the lungs are only going into a state of emphysema over a period of time, and then gradually, because of destruction in the airways, destruction in the lung parenchyma, emphysema worsening, there is a hypoxia, a poor gas transfer from the airways into the lungs, into the bloodstream. So these are the 3 components. So when it comes to inflammation, we all know you need an inhaled corticosteroid to control it in the initial stages. Later on, of course, the oral and the IV corticosteroids. For hyperinflation, you have a long-acting muscarinic agent, that is the LAMA, along with a LABA, that's a long-acting beta agonist. LAMA would be something like a tiotropium or a glycopyrronium, as you know it, and LABA would be like something like a salmeterol, formoterol, indacaterol. These are all long-acting agents. So we no longer use the standard, I wouldn't want to name it because I know we go on YouTube after this, the very commonly used SABA and SAMA combination of levosalbutamol and ipratropium on a regular basis for all these patients. That is only used for a short-term period of say 2 weeks, 3 weeks, but not on a long-term basis. And then of course, as far as hypoxia is concerned, you may want to add oxygen supplementation to these patients, but it is very important to take care of hypoxia in these patients. So what is important is now we've reached that stage where you need to customize your treatment, you need to tailor your treatment. It's no longer one size fits all any longer. It's no longer that just one medication would cover all kinds of COPDs. So you need to identify the endotypes and the phenotypes and then give them the medication accordingly. There are these various COPD etiologies that have been labeled. G is the genetically determined one. So nowadays when we write a prescription, we don't write just COPD. We also try and identify what could have resulted in this COPD and then put a mark there. We may not have specific medications right now for these groups, for different groups, but yes, a time may come when we are able to target all these different groups separately in a very customized and a tailored fashion. So D is for any abnormal lung development, C is for cigarette smoking, P is for biomass and pollution exposure, I is for infections, A is for asthma, and U is for unknown. One marker that I spoke earlier also, which is turning out to be very important, is the eosinophil levels. The eosinophil levels, if there's an increasing blood eosinophil level, they are associated with an increased T2 inflammation, increased mediators, increase in the infections, and also the ICS response is better in these patients. ICS meaning the inhaled corticosteroids. Yet, it is not that every patient of COPD requires to be given an inhaled corticosteroid. There are certain indications that have been very well laid down by the GOLD guidelines of 2025, where they say that anybody who has had history of hospitalization for an exacerbation of COPD, 2 or more exacerbations of COPD in the previous year, blood eosinophil levels more than 300, the absolute eosinophil count, I'm referring to here. So there are labs here. The older labs are still giving you, when you get a CBC done, only give you a percentage of eosinophils, and you can take out the absolute eosinophil count by multiplying it with the total leukocyte count, and that can give you a marker. Or else there are newer labs with those which are using these the analysis machines and the high-end equipment. They give you the absolute eosinophil count as well, like Max Lab does, I know for sure. So you look at the blood eosinophil levels and then decide whether you want to give this patient an ICS or not. And of course, if there is a history of concomitant asthma, in asthma, inhaled corticosteroids continue to be the mainstay of therapy. You could use it if there has been a one moderate exacerbation of COPD per year, or if the blood eosinophil levels are between 100 to less than 300 in certain specific situations. But you do not use it if there has been a repeated pneumonia, because inhaled corticosteroids can result in pneumonia on a long-term basis. The incidence is of only about 4 to 5% of the patients. And then again, it is said that it's usually a minor pneumonia, not requiring hospitalization. So that should not hold you back from giving steroids to your ICS to your patients. But definitely, if the eosinophil levels are less than 100, you would not want to use it. And of course, if the patient has a mycobacterial infection, you would not want to use the ICS. There are various studies which have shown the benefit of using the triple combination, the LABA, LAMA, and the ICS together in these patients of COPD. So this is a study where they have compared LABA, LAMA, ICS versus LABA, LAMA versus LABA, ICS, and versus ICS alone. A very well strategized study, 8,000 plus patients. And what did they find? That when you compare it with the LAMA, that means just a long-acting muscarinic agent versus, and along with a long-acting beta agonist, the reduction was nearly 24% of the moderate or severe exacerbations. With the ICS and LABA, that means the inhaled corticosteroid and LABA, it is only about 13% reduction as compared to the triple therapy. So this is basically a continuation of the same, where they've shown that the combination of the three together is able to reduce it by 49% as compared to 24%, 13%, here it's a 49% reduction in the overall risk of developing exacerbation. And this is about the all-cause mortality was reduced by 49% as compared to LAMA, LAMA, ICS, or other risk combination. The gold guidelines now classify the patients into 3 groups. Earlier it was 4 groups. I remember we delivered a similar talk about a year and a half back when I said that it's being divided into 2 or 4 groups now. But now it has been 3 groups only. Group A is somebody with a CAT score of less than 10 and just very mild symptoms. Group B is somebody with significant symptoms but not having undergone an exacerbation in the last 1 year. And group E basically refers to exacerbators. That means more than 2 moderate exacerbations or more than 1 exacerbation leading to hospitalization would be classified into group E. So in group A, you just give them a bronchodilator like a LAMA preferably. If it's group B, then you would give a combination because the symptoms are significant, so you combine it with a LAMA in this patient. And when it is group E, that is frequent exacerbations, then you must give a LAMA along with an ICS, especially if the eosinophil levels are more than 300. This is what is very important, and this is what is the entire basis, the crux of management of COPD patients in the current settings. There are some other drugs also that we use, roflumilast, azithromycin alternate day, and a new drug that has been introduced is dupilumab, which unfortunately is still not available in our country. So, patients who are already on LAMA ICS, I'm sure you all would have some patient or the other who's receiving a LAMA ICS combination. So, these are all patients who, if are doing well, then it's okay, you may continue with it. But if you give them a triple combination, they will definitely benefit from it. Especially if they have undergone a recent exacerbation, especially if the eosinophil levels are more than 100, then you may want to consider adding a LAMA also to it. The advantage of adding LAMA, that is a long-acting muscarinic agent like tiotropium or glycopyrronium, is that these molecules also act as anti-inflammatory in their own sense. So, there are also studies which have shown that if you delay the initiation of this triple therapy, then of course the odds of exacerbation are significantly higher, as is evident from this forest curve. This was a retrospective observational analysis of patients with COPD, where they had shown that delay in initiation led to severe exacerbation as compared to those in which the triple therapy was started early. So there has been a subgroup analysis also of the previous study that I had shown you, which showed that the annualized rates of COPD exacerbation in a 30-day post-index period were also lower when it was started early as compared to when it was started late, or when it was a LAMA which was started simultaneously, or an ICS-LAMA combination that was started together. And all these studies have been conducted using this molecule, which is called Breztri, and I'll come to that what is so special about this molecule and the delivery device. So COPD is also associated with increases in cardiovascular deaths and cardiovascular events. So if you are able to intercept an exacerbation, to prevent an exacerbation, then obviously you are also able to reduce the overall cardiovascular morbidity and mortality. The damage from exacerbations goes beyond the lungs. It would also result in myocardial infarctions, in neurological strokes, which are increased by nearly 40% within 10 days of an exacerbation. So therefore, is the importance of being able to reduce or intercept an exacerbation. This is again to show that when there was an effect triple therapy on cardiovascular and severe cardiopulmonary events in COPD, which is a post-hoc analysis, and of course, they all favor the combination use of a triple therapy of LAMA, and ICS. So COPD symptoms, COPD exacerbations, cardiovascular events, and early death is the usual cycle. Now, what is important is not just that the patient should be on therapy, but also that the drug that you're giving is getting delivered into the lung. I just met a patient just before coming to this CME here. There was this patient in my clinic who has been taking inhalers for the last, say about 8-10 years, he said. He's an elderly gentleman, 72 years old, had been taking inhalers for the last 10 years, 12 years. I asked him to just show me that, how do you use the inhaler? He said, of course, doctor, I know it very well how to take it. Come, I'll show you. He shook the inhaler, he put it in the 1, 2, 3, 4 puffs, and then that's it. Most of the puff was outside. I said, you know, I think it's a shame on us doctors that we haven't spent that 5 minutes extra with you to explain how to take the inhaler properly. You first need to blow out fully, shake the inhaler, put it in your mouth, grip it properly. The moment you press it from the top, take a deep breath in and hold it there for 10 seconds, because only then will the drug get delivered, right? Otherwise, how will the drug go inside the lungs? It won't. He said, sir, वो तो मुझे मालूम है, पर मैं क्या करूँ? मैं नहीं करता ऐसे. मैं तो ऐसे ही करूँगा. So I said, you know, it's a shame on us that even after 10 years you're not able to do it properly. The doctor said, sir, ये सुनते नहीं है, कोई बात नहीं, let it be. देखा भाई. So how do I shift you from a nebulizer to an inhaler?
You also need to prime the inhaler before you use it.
Only the first time, sir.
Yeah, the first time.
The first time ever when you open the inhaler.
We need to talk about
Absolutely.
this. Yeah.
Very good, sir. Interesting. I know the questions are ready already. Anyway, so coming back to this, so what is important is a proper drug delivery. You know, I'm sure you know of all these micron particle sizes that when they are less than 1 micron, they are easily absorbed into the, you know, we've done this all during COVID times, that what happens during the, in the pollution times, and what happened to the larger particles when it's 10 microns and above, they just get deposited here in the upper airway. When it is less than 5 microns, it goes into the lungs. If it is less than 1 micron, then it would go straight into the bloodstream from the alveoli. So, Breasttree is one such device which is based on an Aerosphere technology, which has these 3 agents, an ICS, a LABA and a LAMA, as I've been saying right from the beginning, a triple therapy combination, where it is shown that it has a 2 to 3 times higher deposition versus the typical MDIs that we use in our clinical practice. This is primarily because it is able to achieve a micron size of 3.3 microns and even lesser, between 1.5 microns is what it is able to achieve because of its delivery. So the drug delivery to the whole lung is significantly higher, 38% versus 10 to 20%. The consistency in the delivery rate from the first to the lines close, so it doesn't need to be primed here, as Dr. Tulsi was mentioning. And of course, there's consistent dosing with minimal shaking, even with a delay of up to 30 seconds from the time it has been shaken to actuation. So it doesn't mean that you just keep shaking, put it in your mouth and just press it. There's still time, take it easy, patient doesn't need to worry about it so much. They've properly conducted scientific studies where they've shown that the deposition of the drug is still the same. I mean, it's pretty good in the lungs. These are the various gamma imaging scans which have shown when they've compared it with a similar triple drug which is being manufactured by another one of the MNCs and is available in our country as well. They've compared the 2 molecules, the 2 drug delivery devices. The molecules are similar, LAMA ICS and LAMA ICS here also. And they found that the drug delivery was better when they were using this particular device. So Breasttree, even in a real world scenario, has shown to be better and has been shown to reduce the risk of exacerbations and lower the all-cause mortality. The code guidelines recommend twice daily dosing for symptomatic COPD patients rather than once daily dosing. So nowadays you also have triple therapies which are available as once a day dosing, but code guidelines recommend the twice a day dosing as the preferred modality. And based on patient preference, study of about 1100 COPD patients, twice daily dosing is what is recommended more often. So this technology is able to overcome the errors of typical PMDIs and maintains a homogeneous co-suspension 30 seconds after shaking as well. So to summarize it all, I would say COPD is a highly prevalent disease. Just one exacerbation requiring OCS and antibiotics increases the risk of hospitalization and a recurrence of exacerbation. The impact of COPD exacerbation goes beyond the lungs to cardiovascular as well as the neurological and the entire lifespan, I would say. Prior exacerbation, breathlessness, productive cough or raised blood eosinophil levels increase the risk of exacerbations and thereby increase disease progression, cardiovascular events and early death. Early intervention is always that is more important. There is an urgent need to prevent these exacerbations. Early identification, prompt intervention, triple therapy has been recognized by code guidelines as the only pharmacological therapy that reduces mortality. And registry is an effective solution for appropriate patients living with COPD. With those words, I'd like to thank you all for joining us this evening. And I'd also like to invite you all for this national conference that we are hosting on the 2nd, 3rd and 4th of May in Delhi at the Meridian Hotel. It will be an honor and privilege for us if some of you could join us, and we'll be happy to have you all with us in fact. Thank you so much.
So I'm sure you would have had two wonderful sessions. I missed the first one, and I would give it to Dr. Sunil Kapoor sir to give his perspective, and I'm sure you must be having questions, so we'll come on the table and you can ask your questions. There are some people who like to have their dinner early, so I would just request Dr. Deven to please serve to those people who want to have dinner on the table. Navy can help you. Please do not go without taking your dinner. It doesn't look nice. So, Dr. Sunil Kapoor sir, your perspective.
Wonderful talk, Amina. What I think is there are other factors like IL-5 reset. Okay. IL-5. Okay. So it is considered that IL-5 is the culprit which causes all this, and Benralizumab takes care of that.
So Benralizumab is an IL-5 receptor antagonist.
I thought that was a omalizumab because.
So anti-IL-5 therapies in India are two, sir. One is Mobashir, which is IL-5 antagonist, and this Benralizumab is an IL-5 receptor antagonist, meaning it will not let the receptor, like it will block the receptor, rendering the IL-5 ineffective. Omalizumab works exactly the same way for IgE.
Right. And question to both of you: there is an asthma COPD overlap syndrome, both of which include the eosinophil involvement, and the medicines and the process of this discovery of Aerosphere. This is very helpful for both of them. So non-eosinophilic and only basophilic, even basophil is considered to be a culprit nowadays. So how do you talk about that?
So basically, sir, this what we're trying to say is that ICS is important in patients who have recurrent exacerbations, who have eosinophilic kind of a picture, whether it is asthma or COPD. So inhaled corticosteroids have to be the mainstay in this group of patients. As I said, when there is somebody with asthma, inhaled corticosteroids, the ICS component is the main line across, right? Across the spectrum of patients. You know, early onset, late onset, mild symptoms, higher symptoms. ICS has to be a part of your therapy. Similarly, in COPD, any patient who's undergoing recurrent exacerbations, eosinophil levels are high, between 100 to 300, and there's an asthma COPD overlap, they must be given an inhaled corticosteroid. When choosing between a LABA and LAMA, we prefer using LAMA in these patients, long-acting muscarinic agent, because as I said, that also has anti-inflammatory effect in addition to bronchodilator. And LABA is only purely bronchodilator. So in COPD patients, on the other hand, in asthma patients, you would prefer a LABA and an inhaled corticosteroid, whereas in COPD patients who are undergoing recurrent exacerbation, you would want to use LAMA plus inhaled corticosteroid with a LABA added to it. So triple therapy would only be better.
You haven't shown the picture of that lovely porous phospholipid molecule on which all the three salts, piggyback, and that goes inside. The thing gets dissolved. It's a part of the surfactant, and the three are delivered far and wide into the chest uniformly.
Okay. So I probably missed that picture. Yes, I admit.
Now to rest of it.
So you cannot take Dr. Sunil Kapoor sir rightly. He is.
We don't take the entire forum lightly, sir, believe me.
He is thoroughbred. Dr. Sen Gupta sir has a question.
Three quick questions, sir. Thank you for two wonderful lectures. So when you are initiating somebody on this monoclonal antibody, as a practical rule, how much do you do, as a step down in the other therapy, just as a practical rule?
So, sir, initially, one wouldn't, start a patient on a monoclonal antibody and reduce the treatment.
No, obviously it's for very advanced and refractory kind of asthma that you're going to do this.
Right, sir. So most of these patients are on multiple therapies. So with the first dose itself, we don't reduce the ongoing treatment. Gradually taper it off. The first to go always is an oral corticosteroid if the patient is on that. And then you go on reducing the dose of the inhaled corticosteroid also gradually again. And like I said earlier also, the first or the second or the third dose may or may not, help you with this. You have to wait it out for 4 months or 5 months till you're able to actually scale down the therapy.
So why I was asking this was, like in diabetology, when you're initiating somebody on insulin, for fear of hypoglycemia, we tend to reduce the dosages of the oral hypoglycemics.
Yes.
In an arbitrary fashion depending upon the clinical experience so that we do not land up with clinical spectrum of hypoglycemia. So, that was a corollary that I was looking at.
Very relevant, sir, but in case of monoclonal antibodies, we don't do that because they're not as fast acting as an insulin would be.
So, second quick question, what are the side effects that you are looking at, and especially with people who have associated metabolic dysfunction disorders like diabetes, hypertension? I'm very sure you'll be getting obese patients who have multitude of other complaints. So, any particular side effects or a red flag signal that you're looking at, ma'am?
None really, none particularly for the people with a metabolic disorder. The only thing that you have to be careful about is an anaphylactic reaction with the first dose, which is why it is always preferred to give it in a hospital setting.
Sure.
But other than that, there aren't many reported side effects also. And we have
totally nephro-safe and everything.
Absolutely, sir. So Benralizumab is indicated for anyone aged more than 12 years. Omalizumab, in fact, can be 6. That's Omalizumab, more than 6.
Sorry? Regarding Mobashir, sorry, you made a comment, ma'am?
6 years.
6 years, okay. And last quick question is, when we were students, there were a lot of talk about mast-cell stabilizers like cromolyn, sodium stuff, and nedocromel and other things. Are they still relevant, or they by and large out of practice? Because they used to be used very much in Australia and New Zealand and one point.
They're still being used in Japan a lot, sir.
Right.
But
we don't have formulations.
not in the guidelines anymore, sir.
Right.
NTR antagonists are there in the GINA guidelines, which is a montelukast which we use pretty frequently, even for a common cold these days. But
those formulations which we used to have when we were students, I'm talking about
Yes, sir.
are no longer available.
the newer drugs at that time, no longer in the guidelines.
Thank you so much.
Just a minute, sir. I'll come. Dr. Narendra Singh, sir.
Amina, I want to tell you my personal experience about Benralizumab. You're telling there is no side effect. The patient has got hives the first day after.
I did mention anaphylaxis.
Anaphylaxis.
Not anaphylaxis. Just go through the effects first. No, sir. Let me explain. This is the first picture, second picture. What is the picture? My picture. I am not.
Mike, sir.
You see.
The Mike.
You see.
Tyson.
And it became just like the skin of leopard.
And we have evidence of urticarial vasculitis.
The patient is in Dubai. He lives in Dubai. The Dubai pulmonologist, they advised him that Fasmera injection. He took first shot. He took first shot. Initially, after 2 days, he developed carbuncle. He ignored it. No problem. After that, he developed multiple 50 watts. Here, 50 watts here, 50 watts there. We ignored that also. No problem. because he was diagnosed as a case of hemophilia.
Should not have been ignored, sir, because this is clearly an allergic reaction
No,
to a
the
drug.
pulmonology one, I'm telling you the pulmonology. I have a senior general physician here. Patient came to me on the second. Then the pulmonologist took it in Dubai. Patient settled in Dubai. Second injection was given. He developed simple like जैसे किसी को pinch कर देते हैं. Then there are pics I am showing you. Second is more ice, more urticaria, then it got converted into urticaria. Gastritis. It was scary for all of us to think with the pain. Family members would run away and you are telling me the side effect. At one point of time, the estrogen people I wanted to tell, I discussed this whole this was then he went to the pulmonologist. That time it was stopped.
So there is nothing absolute in medicine. That only goes to both ways. No one will say that there is no side effect. Nobody will say that. There can be a side effect, and arterial vasculitis, was it proven by biopsy, sir? Alright. So we take your point, sir. Point well taken, sir. Point well taken. Thank you for educating us. So there are side effects that we must be aware, and there can be very rare side effects of a particular drug which we cannot discount. So that is the point well taken, sir.
When I explored it further,
Mike, sir.
when I explored it further, that time it is mentioned in the literature by the AstraZeneca that after many days it can get converted into urticaria and urticaria of that. After many days, not that आज आपने short की है थोड़े दिन बाद होना. After days also.
So you can have it.
Yes.
So whatever is there, but
Right, sir. We need to move. Thank you, sir. Thank you so much. No. Thank you. It's a point well taken, sir. And it's an education. That's why we say we keep learning every single day of our life. My question is there a role for oral steroids these days? And what is that setting where we would like to, Dr. Nangia told us about the inhalation corticosteroids. But when we were doing our PG, we were also using oral steroids. So is there a role for oral steroids?
Absolutely, sir.
Which patients do we reserve them for?
See, so basically for COPD or for asthma, both any of the biological agents will not act during an exacerbation. So if a person with asthma or COPD is coming to you with an exacerbation, there is mentioned even in the guidelines.
Short term only?
Yes.
Any need for tapering them or just give them slam bang and stop them?
So it depends on how the patient is responding and what dosages we are giving.
Okay.
So if you look at the gold guidelines, they have a very blanket dosage of 40 mg of prednisolone for all the patients with COPD, which we do not normally follow in the real world. We titrate and taper the dosage based on the body weight. But certainly in cases of exacerbation, there is a role of oral steroids.
So there is a role for them still. There's a role for them still. Any question from that side? All right, Dr. Tulsi sir.
So those were some wonderful talks, Dr. Amina and the master pulmonologist and the best critical care specialist, Dr. Nangia. So Dr. Nangia, you talked about...
Whether that is sarcastic or a compliment, I'm
No,
not
sir. Do I look sarcastic? Okay, sir. Let me proceed. But Nangia, you said COPD is often underdiagnosed. Is it because of the chronicity of the disease as compared to the acute bronchial asthma? People do not recognize the symptoms earlier in COPD as compared to the acute exacerbation, acute asthma. Tell us, sir.
Absolutely, sir. I agree with you. In fact, that is why they have come in with two new terminologies also, the pre-COPD and the PRISM. That means somebody with a preserved respiratory, the PF, the FEV1. So what is the classical definition of COPD is that you have to have a PFT which shows that the FEV1 by FVC on that PFT is less than 0.7. But how many of us get a PFT done the first time when the patient comes to us? We don't. We prescribe their medication, we send them back, 2 weeks later the patient may or may not come because the symptoms would have got resolved. It's only when the symptoms persist that you get this PFT, CT scans and all those done. Otherwise initially you would not even get these tests done for your patients. That is why it is underdiagnosed.
You also talked about, early recognition, important to reduce exacerbations also, because this would increase your morbidity and mortality in such like situations. So herein lies the fact that you probably need to give monoclonal antibodies here for resistant COPD or bronchial asthma. And if you had to give a map, which is the map you choose? Would it depend upon the eosinophilic phenotype or would it depend upon the inflammatory phenotype? Tell us, sir.
Right. So basically, sir, as far as the maps in COPD are concerned, there are still studies ongoing. The only map which has been approved for COPD is dupilumab. That's the only one that has been approved, sir, yet. And dupilumab is also to be used in a patient who is on a triple combination therapy and is still not improving. That is when you would give dupilumab to these patients. Otherwise, as far as the MABs usage in asthma patients is concerned, you have to phenotype your patient based on their IgE levels, their eosinophil levels, and then decide which one you want to use.
Right. My last question to you would be regarding ensifentrine, which is a dual
PD4 inhibitor.
and PDE4 inhibitor.
Yes.
So this is an inhaled medication.
Absolutely.
So is it available today?
Not yet, sir.
Not yet.
Available in India. We have no experience of using it. It's a twice-a-day drug. That's all we know about it.
So
And safe to use and effective.
very safe, very effective. This molecule has come in almost over a decade now.
Yes, sir.
Thank you, sir.
Sir, I am the last person to ask very few questions.
Thank you, sir.
I have to start from you, sir. In your one of your slides, you
This
said
time I must say, sir, Dr. Tulsi has been very generous and very...
you labeled Group A, Group B, and Group E. In Group A, you said only bronchodilators. Are ICS not related here?
Sir, basically, sir, in COPD, you would want to restrict the usage of ICS unless patient is going into repeated exacerbation, eosinophil levels are high, or there is an overlay of asthma in these patients. Otherwise, this is one group which you only require bronchodilators. So if somebody has only mild symptoms, has not had an exacerbation in the last 1 year or so, or maybe just a mild exacerbation where he did not require to be hospitalized, did not require very prolonged oral steroid, in them there is no need and has no much symptomatology. In them you just give them a LAMA is what we prefer because it has anti-inflammatory component also. Just LAMA once a day. Also if you look at it the reverse way, that you start somebody on a triple therapy. Now how do you de-escalate the therapy? Some people say that you continue the triple therapy endlessly. Others say that because there is a risk of pneumonia developing after 1 year or after 2 years, when if you go by the criteria of E, A and B groups, if the patient shifts from group E to group A or group B first and then group A, then you may consider shifting them, de-escalating them from stopping the ICS first, then giving LAMA, then once the symptomatology is reduced, then scale them down to only LAMA.
Sir, one point about eosinophilia. Since we have a prevalence of wands in India, to the extent that we have a creamy day, one day is fixed for everybody to be given anti-worm medicine. So having this background, eosinophilia, is it how important it is and what is the cutoff level? That after this level you will take it for your importance in the...
I fully agree with you, sir.
Yeah.
What you are saying is a very valid point, that in India you presume the eosinophilic levels to be slightly higher than what you see abroad. That is why they've kept 300 as the cutoff. Of course, in India, we don't have any studies like this, which correlate it because these studies are not so simple to perform. They also include the biopsies from the lungs, the eosinophilic infiltration into the tracheobronchial tree and all of that and then comparing with the blood eosinophil levels and then seeing the impact. So we really don't know the cutoff.
Thank you, sir. The case Dr. Narendra was presenting, was it something related to or akin to Stevens-Johnson syndrome?
Could be, sir. It may just be progressing towards that.
Sir,
but
my last question.
as Dr. Chauhan also said that there is no medicine without a side effect. Our belief also is that if there is an effect, there has to be some side effect or the other of the drug.
My last question. So, Benralizumab, as you said, it is wonderful medicine. Are there any endotypes or phenotypes of asthma which are specific for this? Which candidates for Benralizumab?
So first of all, Benralizumab is not indicated for each and every asthma patient. It is only indicated for a subsection of Benralizumab. So you will give them LAVA, LAMA, ICS, LTR4 receptor antagonist, and you literally throw the kitchen sink at them. And even after that, if you have a patient who is not responding, then and only then comes the role of biological therapies. Now in this, where specifically Benralizumab is indicated is in a subset of patients that have eosinophilia, that have a high IgE level. It responds very well in patients who have nasal polyposis, but then again I would like to reiterate that not every Tom, Dick and Harry should be subjected to it, but in patients who do have severe asthma, and we have quite a few of these patients coming to our clinics. So this subset of patient definitely, as per the guidelines, as per the recommendations of the GINA, should be given a trial of biological agents.
Dr. Kala sir, you mentioned about Dr. Nanda Singh's case and you mentioned about Steven Johnson. Yeah. I don't think there was any mucus involvement. There was only cutaneous involvement. There was no mucocutaneous syndrome. It was only the skin. There was no oral mucosa involved. So I don't think it was Steven Johnson. It was probably a cutaneous syndrome only. But anyway, we have discussed enough. Sir, I wanted to ask regarding a subset of childhood asthma, where we have small kids who actually have reflux and they present as asthma. Sir, how do you tackle these people and what is your line of investigation?
So basically, if you see that what are the common causes that precipitate asthma, besides allergy, besides the environmental factors, and associated rhinosinusitis and reflux. These are the two most common causes. In fact, we've had patients, I've had my own couple of patients, in fact, in the recent past, which have been like enlightening for us also. Like every patient teaches you something different. His patient's cough was not settling. You would give them oral steroids, 2 weeks, 3 weeks, oral steroids, cough would settle. 1 week later, the cough would come back again. Inhalers, asthma, cough. This vicious cycle went on for 3 months, 4 months, 5 months. Finally, I don't know what came over me. I said, yeah, this could just be reflux. Get your endoscopy done. We got the endoscopy done, RUT positive, started him on treatment for H. pylori, and he hasn't come back to me after that because his asthma settled completely, his cough settled completely. So this was a learning lesson for me. This happened about 2 years or 3 years back. Since then now, any patient who has cough not settling despite your steroids and treatment or recurring so often, we get an upper GI endoscopy along with a bronchoscopy done, rule out the infection in the lungs, endobronchial infections. We've had a young girl who was a doctor herself from Sunil Hospital who kept having these recurrent exacerbation of asthma. We did a bronchoscopy and there were endobronchial nodules and it turned out to be tuberculosis. And CT plumb normal. So endobronchial TB could be a mimicker of asthma. Reflux is a very common mimicker of asthma. So you treat the reflux, asthma comes under control. 80% of the patients have a rhinosinusitis. You treat their rhinosinusitis, the asthma comes under control. So they're all interlinked.
Sir, another question which I wanted to ask both of you, anyone can answer or both of you can answer. There are a lot of parents who come with children and they say कि दिल्ली के अंदर 12 में से 2 महीने जो है AQI जो है 300 से ऊपर है. There are parents who are willing to shift out of Delhi, so much so that one of the parents who can be probably got a job in the hills he is working on dam, so he says that I have the option of going to the hills and working on Tehri dam, etc. etc. What kind of advice should we give to those people whose children actually have very severe asthma, almost not responding to anything, and we might actually need one of the monoclonal antibodies? Will this advice work if they leave Delhi and if they go to the hills?
Very good question. So I think one first thing is that you have to find out what are the triggers for asthma in this child. Is it just the environmental factor or is it more to it? Like I said, this rhinosinusitis, gastroesophageal reflux, any particular allergies, for all you know, there may just be a pet in the house which is causing this allergy to them, or a particular carpet, or the house dust mites, any chemicals, somebody lighting agarbatti in the house, dhoop in the house, so there can be hundreds of triggers. So first and foremost is to identify what that trigger for every individual is. Now I have this patient of mine who gets triggered whenever he goes to a hotel and stays the night there. So he came and told me, sir, whenever I go to the hotel, I get this problem. I kept thinking, what could it be? Then I said, you always go to a room where it's carpeted. He said, yes, sir, that's the reason. I said, that's the reason. That whenever you go to a carpeted room, it's the carpet which is trapping all the dust and causing you this problem. We had the former CEO of Fortis Hospital come to me with cough, phlegm, breathlessness. He said, the moment I go to Spain, I'm absolutely alright. Whenever I'm traveling abroad, I'm absolutely alright. But when I come back to Delhi, I start having this cough, start having this wheezing. So I was at Escorts one day from Fortis Basantkuj where we used to work. I got to Escorts to see a couple of patients there. And I just happened to walk into his office. And he turned around, he opened his cabinet to show some papers to me. And I realized that the entire cabinet was infested with fungus in that wall. The moment he changed his office, his cough just settled. He never came back to me after that because the cough disappeared. So again, you have to identify what is causing it. If despite your identification, you've not been able to find out the main cause and you want to attribute it to air pollution, then first thing I would say, rather than asking the family to translocate completely or relocate completely, first try it out that whether it really works or not. Give them a 3-month period like a summer vacation, okay, spend the summer vacation in that area and see if it works. If it works, very good, then I guess there's no other option. There are studies which have shown that children who have, comparing the children going to school here in Delhi and children going to school in South India. I've forgotten the names of the two cities. So there were 3 schools that were covered and they found that the children from Delhi had much poorer lung functions as compared to those schools which were in the green valleys of South India. So it isn't unscientific to be saying yes, the air pollution is reducing our quality of life, our average lifespan, but then again you need to try it out first before asking somebody to relocate completely and then find out कि वहाँ भी जाके आजमा ही हो रहा था, वहाँ पे कोई और pollen आ गए. In those areas there could be different pollens in different seasons. So these are all things that you need to keep in mind.
Dr. Sajid Parvez.
Thank you very much, sir, for a very informative session. 2 things I have in mind. Sometimes I have seen patients with anxiety, generalized anxiety disorders falling into the trap of asthma or wheezing. Is it there? Have you seen such patients that which do not have any other thing, but only anxiety that precipitates the wheezing and the asthmatic pain? Another thing is, sir, in chronic COPD patients, as well as patients with ILD, is there any role of therapeutic BAL, bronchoaspiratory lavage? Is there any role?
So you're asking the wrong person, sir, because our answer would be absolutely yes, that it is. All these patients of COPD who have been on medication, not improving, they must undergo a bronchoalveolar lavage, because what we've seen from our practice, we haven't published it though, but this is, we haven't seen. Okay, so they improved symptomatically, because what happens in all these patients, and we strongly believe, is there is this micro plugging of the smaller airways, which is not relieved with all normal medication, with all your mucolytics. So when you do the bronchoscopy and clean their lungs from inside, believe me, I'm not joking, 90% of the patients tell us the next day, doc, we are feeling so much lighter in our chest that we should have gotten it done much earlier. Way back when I was in Batra Hospital in 2007, 2006, I used to have this patient come all the way from Rohtak to me every 3 months, doctor, bronchoscopy kar do meri. And I would say, ek baar kar di, ab nahi kar.
So how long does it help?
No, sir, it is only a transient phenomenon. It helps you diagnose the infection, and second, it gives them temporary relief till the time your drugs are effective. And after that, if they are on a continuous medical therapy, then usually the recurrence doesn't happen and usually you don't require it. As far as an ILD patient, bronchoscopy is very, very important. Especially if the patient is not settling or not doing well despite your therapies, despite steroids, because what we've seen is many of these patients which have interstitial lung disease, their shadows on the CT scan overlap with those of infections like cytomegalovirus pneumonia, like pneumocystis jirovecii. So in those patients, if you're able to do a bronchoscopy and prove one of these infections, you can treat them. Their symptomatology comes down significantly. Right now we have a patient admitted with us, being treated at another hospital for pulmonary tuberculosis. 6 weeks of treatment, rather than improving, the patient was only deteriorating. We repeated the bronchoscopy in our center, checked for it again, and we found cytomegalovirus positive. We are treating for it for last 1 week. The guy who came to us on 6 liters of oxygen today is off oxygen in this 1 week's time. So tuberculosis was one aspect, which of course was gene expert positive, I'm not denying it. But nobody looked for associated infections alone.
So my first question is anti-anxiety treatment of any help?
I forgot that, sir. I fully agree with you again. So anxiety, any kind of emotional distress is a precipitating factor for asthma. Not for COPD, but for asthma, yes. Now, what happens is that it is important at this stage to be able to differentiate whether the patient has an asthma or is it a panic attack. You know, sometimes when the patients come to you, you may not find that apparent wheezing. The patient may not be able to cooperate with you. So in these situations, getting a PFT or a peak flow meter would be handy. Or what we do is in these patients, we give them a peak flow meter, कि भाई घर पे check करते रहना. You know how you remain, keep monitoring it, keep writing down what your peak flow rates are. Based on that, then we can decide what the future course will be. But yes, emotional turmoil, emotional distress is a factor which can precipitate asthma very easily.
Thank you so much, sir.
Dr. Manu Saxena, sir.
So just one last observation only. When Dr. Chauhan asked you about shifting out, I had an aunt who is a doctor herself. She was the leading gynecologist of Haridwar city. For 20 years she had asthma, and being a doctor herself, she knew many doctors, and there was no treatment. Then ultimately, when she moved out of Haridwar, her 20 years asthma became alright. It was found that there is a grass called parthenium. That is the cause of asthma. That's all.
So that's what I said, so that it is important to know what is triggering off your asthma. That you leave Delhi and go to Haridwar and it doesn't improve there also because they were allergic to something else there. While the AQI has improved, but then something else is triggering off your asthma. So it is important to identify the cause, what the trigger is, and then consider what you need. And it isn't that asthma doesn't happen in the US or in the UK, despite the AQI levels being 3, 4, 5. Even there, asthma does happen.
So there are two last questions that I would like to ask. So there is a group called the drug-induced asthma, and classically induced by aspirin. And there are a lot of people because of in the elderly age, post 60, because one reason or the other, especially because of coronary artery disease, atherosclerosis, diabetics, etc., they are on aspirin. How do you know that it could be related to aspirin? Is it the presence of polyps in the respiratory patches that would attract your attention, or anything else? Any marker?
So this is like an MCQ that you usually ask the PG questions. That you know, if you're getting nasal polyps with asthma, what is the first thing that you would think of that is causing this asthma is aspirin sensitivity. So it is the most common thing and most common link between all these three entities. But the only issue is that at that age it becomes difficult again to diagnose, you know, with somebody who's on aspirin and still not developed the polyposis. Does that mean that it is not aspirin-induced asthma? Well, it could still be. But yes, it becomes a tricky situation.
Sir, although the topic was not about the other novel techniques that we use for asthma, Dr. Amina would remember one patient who came to Saudi Arabia, Mr. Javed, and he was admitted with severe bronchopulmonary aspergillosis. And he was really very bad, he could hardly travel. And then you kept him for about 5-6 days and you did some procedures, especially bronchoalveolar lavage, almost cleaning of the lungs, and he went off very happy. There is a technique called thermoplastic. This is available for treating asthma. Are you people doing it in Max? And what is the role and where is it used and what is the cost?
Very good question, I mean, very valid point. Bronchothermoplasty came with a huge bang about 3 or 4 years back. Everybody started talking about bronchothermoplasty. We also did it in 2 patients, both wonderful results. But somehow, the technology has not picked up beyond that level for some reason. truly, if you ask me, I am also not very clear as to what happened to it and why it is not being used so much. Is it because the company itself withdrew for some reason? You know, there are times when there are drugs launched. Like if you would all remember, there was a time when Zygris was launched as a drug and was considered a miracle drug for treating sepsis. And then suddenly one day, the company stopped manufacturing it and there was no talk about this drug ever again. You know, nobody even communicated that why it has been withdrawn. You know, a drug which at one time was costing 4 lakh rupees to your patient and was being promoted so heavily was suddenly withdrawn, that rotigozin alpha. So similarly with bronchial thermoplasty, we are not very clear. Even the company has not ever told us the exact reason that why the technology has been withdrawn or is not being promoted. So truly I don't have an answer to that.
Is there a special approach needed for people with bronchopulmonary aspergillosis with asthma versus asthma alone? Are different triggers there? For ABPA with asthma, we have to take care of certain other things apart from taking care of the usual things that we take care of in asthma. And are there any monoclonal antibodies directed especially against ABPA?
I guess Dr. Amina will.
Benralizumab does work for ABPA, so even Benralizumab works for ABPA. I think our patient that we were talking about was on some form of monoclonal antibody back in Sunil.
He was given one shot, and then he was not sure whether he should take those monoclonal antibodies. So I called him and then referred him to you. He is very happy, by the way, he's gone back. And so that case only aroused the curiosity that for these kind of people also we can think of these novel techniques.
So the 2024 ISHA guidelines, which are like the Bible for the treatment of ABPA, have mentioned the use of these monoclonal antibodies if of course the patient is not responding to the standard treatment.
Right, I think we had two wonderful sessions. Dr. Sanjeev, you did not have your dinner. We would like that you have your dinner, and ma'am also. Dr. Savita also. Please have your dinner. Just have sweet dish. Don't have your dinner. Just have sweet dish. Only sweet dish. That's all. I would like Dr. Sunil Kapoor sir to give his perspective, the final perspective, the summary of the talk for carry home message for all of us.
It's been a wonderful set of talks by Dr. Amina and Dr. Vivek. Firstly, the delivery of drugs has always been a trouble because reaching the right place in good amounts is always a challenge. And the Aerosphere technology is a good new kid down the block, and it should do very well. But when Benralizumab, it's new, it's a discovery, and it's been used in the advantage, especially in eosinophilic cases, asthma and COPD, and their overlap. And I think it should be a very good addition to the armamentarium.
Thank you very much, sir. Lalit, I would like you to have thank you so much for pitching in today. Dr. Vivek sir, Dr. Amina.